All right, hello everyone. I think we'll go ahead and get started. It's about noon. It looks like we've got a number of participants still signing in here and getting started, but we'll go ahead and get things rolling. All of our time is kind of at a premium these days. But I want to thank you all for showing up here virtually and attending our orthopedic little case review here this afternoon. Hopefully you're enjoying lunch and enjoying perhaps the outside a little bit. It's a beautiful day. I'm kind of stuck in a little room here in the office, but folks like me with pretty bad allergies, maybe that's a good place for me to be. I don't know, but hopefully you can see the sun and enjoy it a little bit. And happy to have you guys join us. We got a lot of participants today, which is good to see. Some interest in orthopedic cases, and we're just going to kind of run this like a little case review, kind of like we all did back in vet school, and kind of go through some cases. I think we promoted this as maybe looking at some tricky or interesting or unusual cases, and I've got a few of those I think we can go through, but I also wanted to include some cases that maybe you see more commonly, in your practice, and give you some ideas on what you could do with those, or some ideas on how to progress with some of the more common questions that we get from veterinarians out there. So hopefully we'll touch on a little something that you guys can take back to your practice on a daily basis, and get you some little nuggets of information that you can use day to day. Just as a little bit of logistics, I think we're all probably getting pretty used to these Zoom calls and presentations and such, but if you're having technical issues, I think go to the chat section, and my IT assistant, Izzy, here will help you out with any kind of technical issues you're having. We are going to try to make this somewhat interactive if we can, so we'd like to get questions from the audience and the participants, and if you have questions that come up, go to the Q&A section, and we will try to address those questions. I think I'll probably just pause in between each case and we can try to answer questions, but feel free to start typing your question as you go, and we'll try to get to them in between cases. So with that, I think we'll just kind of jump in and get started. For those of you that don't know who I am, my name's Alan Johnson. I'm a surgeon and one of the owners here at Animal Surgical and Sound. I did my residency way back when at Michigan State University. I stayed on there for a couple of years on the orthopedic faculty side of things, and then ended up moving out here to Seattle in 2002. So I've been here about 19 years this summer at Animal Surgical. So just a little bit about me, and then I also want to, from the get-go here, just thank Hills and Elanco for sponsoring the event and helping defray costs for us to put this on. So with that, I think we'll jump into it and get right to case number one. Perhaps some of you out there will recognize some of these cases. I kind of left names off and such to make it a little bit more anonymous, but let's just get into it. So case one's a 5-month-old little pitty. I think we're all seeing lots of puppies these days, and little traumas, that are going to happen with puppies seem to be pretty common. So we're seeing a bunch of these cases. So this is presents, to your office, basically acute onset of left hind limb lameness after jumping or falling from the bed. Pretty common history for these little guys. Jump out of the owner's arms, try to jump on a bed, jumping after a ball, come up, acutely lame in the left hind. Exam findings, basically determine there's a weight bearing but pretty severe left hind limb lameness. The stifle seems to be the source of the issue. You get a reaction to palpation, especially flexion of the stifle. no instability though in the stifle, so negative drawer, negative tibial thrust, the patella is stable, everything feels good anatomically, but some reaction to the stifle. Rest of the orthopedic exam considered within normal limits. And so just to put together a little quick differential diagnosis, what are we thinking about here in this 5-month-old with, kind of mild to moderate trauma, but pretty significant lameness, certainly growth plate injuries, some sort of trauma or fracture is going to be high on the list. Congenital orthopedic problems, OCD, yeah, possible, maybe cartilage flap just detached, just moved, became acute onset of lameness. Partial Ccl tear, I mean, anytime you're dealing with a stifle, you like to put Ccl tear on the list, but at a 5-month-old, that's going to be pretty uncommon to see them tear a cruciate ligament, but probably on the list. And then, of course, other sprains or strains or other soft tissue injuries. And so, kind of the go-to option is going to be to take some radiographs and try to determine if we have some sort of more significant trauma, especially around the growth plates for these youngsters. So started off, these are, kind of referral films. So this would be a typical question, from one of our veterinarians out there after they take these films, kind of what do you see going on? I'll give you a little second to take a look at it. The pelvis, pretty normal, for a puppy. These guys are always hard to interpret with growth plates and cartilage and such, but no real obvious abnormalities in the pelvis. When we look over at the left stifle, we're kind of looking, I'll get my cursor to come up, hopefully you guys can see that, but looking at this tibial tubercle area, it seems like we got maybe some soft tissue swelling around the tubercle. We've got a little bit of a bony, either reaction or mineralization here, kind of in that tibial tubercle growth center. The rest of the joint really looks pretty normal. Maybe there's a little mild effusion there, kind of questioning that. The rest of it looks pretty normal. I think the thing to remember with some of these, when you're trying to determine with these puppies, is this normal or not normal, is we do have another limb we can look at, right? So in these dogs, we can always x-ray the other side and can compare that. So we've got kind of a built-in normal to go to. And so we take the right side and looking at the tubercle here, and we assume this is our normal side, and we compare it here. Looks like we've got a little bit wider gap here on the left side. Again, we got this little mineralization we don't see over there. So what we get as a diagnosis here is we have a partial avulsion injury of the tibial tubercle. So we'd call it partial or minimally displaced tibial tubercle avulsion. And of course, the biggest question we get pretty consistently with these is, is this surgical or is this not surgical? And most of these, we're kind of looking at how significant is that displacement. When we have a partial situation or a minimally displaced situation, typically we lean towards more non-surgical management. You got to remember with these guys, they're young, they're going to heal really quickly. That level of displacement is really pretty minimal. And probably, if we were going in there and looking at it surgically, we would guess, probably 70–80% of the periosteum is probably still intact around that tubercle. That thing's probably being held on pretty well, at this stage. The advantage, if we don't have to go to surgery, is we don't have to stabilize that tubercle with K-wires or tension band or something that may slow down or prevent continued growth of that tibial tubercle. So ideally, we'd like to go more conservative, maintain some growth of that tibial tubercle if we can. The trick is often, preventing these puppies from being too active with it. So typical case like this, that would be our recommendation. Let's go conservative, non-surgical if we can. And again, what you have to remember, these youngsters are going to heal really quickly. I mean, within a week, this tubercle is going to be pretty solid. So I would typically put these guys in some sort of bandage, perhaps a splint, to just mostly keep the bandage in place so it's not slipping down around the dog's ankle or something like that. If you put a little lateral splint in there, it'll stay in position better, and remind the patient and the owner that things aren't completely healed. A lot of these guys, if they're feeling good in 3 or 4 days and they're wanting to be active again, the owner lets them again jump off the couch or do something like that, then that's how you can get these things to displace. So we'd go exercise restriction, smaller space, X-pen type thing, bandage, for maybe 2 weeks, 10 days to 2 weeks probably. I think an important thing to think about would be repeating the x-rays in about 5 to 7 days. And so if you get them in, just a quick lateral x-ray, take a look at that tubercle and see if it's displaced at all. Now that x-ray is not going to look much different. Hopefully it's not going to look much different. I'm getting a little information that we're having some issues with the sound. Give me 1 second. I think we're good to go. Okay, so just backing up, but when you take this x-ray, let's pretend that this is our x-ray 5 or 7 days from now. This is what we're hoping to see, is basically the same thing. We're not going to see this area fill in. This is still going to be cartilage, and that's what we want to see. But if this tubercle hasn't moved in a week, it's probably not going to move again unless the dog has very similar trauma to the original injury. So you can start to feel pretty comfortable. Some of these cases we see come in a week or 2 after injury, and you go in there surgically, it's pretty impressive, how much scar tissue and fibrosis and such they have around that area. So these things stabilize pretty quickly. So the take-home message would be if it's partial or minimally displaced, and this kind of goes for a lot of our growth plate injuries, we're going to try to treat those non-surgically, conservatively. In comparison, so this would be what we say is a displaced tibial tubercle avulsion fracture. So this was a 8-month-old little Frenchie that avulsed this tubercle. We didn't see it here at the surgical clinic till about a week after injury, but what you can see is a fair amount of soft tissue swelling around this area, and you can bet there's quite a bit of fibrosis in there. But this guy's displaced, so we would typically recommend surgery for a case like this. These are just a couple intra-op fluoroscopy images. This little piece of bone is kind of tricky to identify in there at surgery. There's a lot of fibrosis around that, and you're trying to identify that piece. So it certainly can be helpful to use a little fluoroscopy, make sure we're engaging the pins. It lets us be a little bit less invasive, and we can find that piece, get a couple pins in there, and hold it. And this is just that case, 4 weeks post-op, just making sure things are looking good, that our pins are stable, nothing is migrating on us. We have some calcification happening in here. Again, these aren't going to look like, oh, they're fully healed. We could take those pins out, but we certainly could take the pins out. 4 weeks, that thing is going to be solid. It's not moving. In this case, it's a 9-month-old Frenchie. We don't really have a lot of growth left, so we're not really worried about growth potential. We're going to leave those pins in unless they prove to be an issue. With loosening down the road, we'll take them out, but otherwise we're leaving those in. All right, that was the first case. I don't know, do we have a couple questions? Well, let me see here. Am I pulling these up? They're not coming up on my screen. Hold on one second, trying to get the question. Would it be best to send the dog, the rads to a radiologist or to you to decide the tibial crest is minimally or more seriously displaced? You know, it's a great question. I think, you know, if we're trying to determine is this surgical or not, I would send it to a surgeon versus a radiologist. I mean, they'll describe it and they'll say how displaced it is and such, but, you know, that kind of clinical assessment on whether or not, you know, it's surgical, I think best to just send it to us. And we're happy to do that. I mean, that's, you know, something that we try to be very available. We've got 5 of surgeons here, and you know, we try to be available at most times. If you call up or can send us x-rays, we can tell you straight away, you know, should this be sent for a surgical consult or not. I think with all of us, you know, during these COVID times, we're all pressed for time and you know, we're booked out further than we've been booked out for a long time. And so we do try to prioritize fractures and getting them in a timely manner. And so that helps us. Actually, you know, if we looked at the x-rays and said, yeah, we need to get this in, we'll make room for it and get it in. You know, if it comes in and it takes up kind of a fracture slot for us, and then we find out, yeah, it's not very displaced, we're going to go conservatively with this. It maybe, you know, kind of blocks an appointment for another potential fracture. But yeah, we're happy to talk to you on the phone, send us the x-ray images, and we can give you an assessment. Usually pretty quickly within, if not right when you call, but within a few hours or so. Do you do anything for pain control for case 1? Yeah, typically, you know, we probably go with a non-steroidal anti-inflammatory if the dog tolerates that okay. You know, maybe some gabapentin is a little bit of a sedative and a little bit of a pain reliever, but probably primarily the non-steroidal anti-inflammatory. You might only need it for, you know, even a week or a week and a half or so. Most of it's going to come down to sedating these little guys so they're not too active. Did you use NSAIDs or analgesics? I think we just covered that. How long do you activity restrict these guys of treating conservatively? So I think had it on a slide here quickly. I think what I usually do for these guys, or what we kind of recommended in this case, I think the first 2 weeks are really the most important. If we can keep them really controlled for 2 weeks, and then I usually just tell the owners take another 2 weeks, and kind of gradually ramp up their activity back to normal after that. Again, after 2 weeks, it's probably not going to displace unless they do some big jump or have some big trauma. But I think it's probably worth telling the owners, you know, about 4 weeks of confinement and controlled activity on a leash and kind of gradually ramp them back. So that's kind of the typical protocol we would do. Is that it? One more question. Post-op bandage for the surgical case needed? Needed is probably a strong word. I think I did put this dog in a little bit of a bandage, mostly just for soft tissue compression, and to, again, just kind of keep this puppy a little bit more restricted in that first week. So I think I did about a week of a bandage, and then we took it off at that point. Just went with exercise restriction from there. All right, Izzy, we good? Okay. Let's move on to the next one. So case 2, this is a 2-year-old, about 60-pound border collie cross, presents to your office with acute onset of right hind limb lameness. Kind of the history is the dog was totally normal, no problems in the past, was playing fetch, took a big jump up for a ball, landed, yelped, and was immediately non-weight bearing on the right hind limb. Gets into your office, exam findings, there's some pretty obvious effusion in the stifle, and the doc seems pretty sensitive to the stifle. So maybe a little bit more reactive than you would expect to that stifle palpation. But there's no obvious draw or instability noted in the knee, and the rest of your orthopedic exam is considered within normal limits. And so, again, we put together in our heads, right, a little differential diagnosis. Cranial cruciate ligament tear, obviously going to be on the list of a possible differential diagnosis. It would have to be partial though, right? So this dog, we already assessed it as not having any instability. So it would have to be a partial tear to be a cranial cruciate ligament tear at this stage. Some other stifle sprain injury, collateral ligament injury, certainly could be on the list, although that would be a partial strain type injury if we don't have any instability there. Meniscus tear, yeah, certainly possible. Happens in people all the time, right? Where you can tear your meniscus without tearing your ligament. I've seen only one dog in what, 23, 24 years of doing this that tore a meniscus with a stable knee. So it doesn't happen very commonly. Usually we think of meniscal tears as kind of secondary to ligament tears. And once that knee becomes unstable, then they tear their meniscus. So pretty unusual to have a solitary meniscal tear with even a partial tear of the cruciate ligament. Fracture, would be on the list. I mean, it's kind of unusual, right? Jumping for a ball. Could be on the list given the level of kind of pain and inflammation and non-weight bearing lameness, and then some other soft tissue injury. So here we're going to send out a little poll to the audience and see what you guys think. A little question for you. Don't worry, it's all anonymous, so nobody knows what your responses are. So go ahead and weigh in here in the polling section on what you guys would do if this dog came into your office. So our options are A, we do some NSAIDs, pain meds, rest for a couple weeks, recheck if not improving. Do we go straight to recommend x-ray of the stifle? Do we do no radiographs and just refer to a surgeon at this stage, thinking it's got to be at least a partial tear of the cruciate ligament? Let's just go straight to the surgeon. Other option, do we do, based on the amount of fusion in the joint, do we do a stifle joint tap and evaluate that? So those are the options I put out there. We'll give you just a few seconds to everybody get a little vote in here. Does everybody get to see these results or just us? Oh, we can show them? Okay. We'll give you just a few seconds here and then we'll show the results. So here's the results. Majority of you, 70% saying radiographs to stifle. I personally like that idea. I mean, that's what I would say would be a good choice to recommend, and mostly based on the severity of the lameness, the effusion, the pain in the stifle. I think it would be a good idea to radiograph the stifle. Now, I think, rest and NSAIDs for a couple weeks, may not be a bad idea as long as you're kind of keeping track. Does this dog improve? Clinically, does it get back to weight bearing in a couple of days, or what happens there? But I would agree. I think radiographing the stifle, is the ideal option based on what we talked about there. Let me see. How do I get to my next slide? Sorry, slight technical difficulty. So what happened actually with this case is there were no radiographs taken. It was kind of more of, let's go the rest and pain med route with the assumption that this was going to be a partial cruciate tear. Um, the dog ended up improving mildly, but not significantly, and then ended up coming to us about 5 weeks post-injury. So it had improved a little bit. It was weight bearing, kind of more of a moderate weight bearing lameness. Still on carprofen twice a day at that point. Examination here still had pretty severe stifle effusion, a lot of periarticular thickening around the joints, decreased range of motion, maybe a little crepitation in the joint. Still no obvious earpiece there. Still no obvious instability. So negative drawer, negative thrust, collateral ligament stable, and definitely reactive, to kind of pressure over the distal femoral condylar region. So, our diagnosis list kind of changes a little bit at this time. We're 5 weeks into it. We've had a little bit of improvement clinically, but certainly not what we would expect from a partial cruciate tear, right? So if this is a partial cruciate tear, maybe they have a day or two where they're non-weight bearing, but with some NSAIDs and some rest, we would expect pretty significant improvement, maybe not back to normal, right? But using the leg pretty significantly and maybe some ups and downs with a partial cruciate tear. So the fact that this dog is still pretty lame and pretty protective of this knee at 5 weeks post-op while still on NSAIDs, makes significant trauma like a fracture certainly goes up higher on the list at this stage. Neoplasia, certainly based on palpation alone, neoplasia would be on the list with a fair amount of thickening, reaction around the stifle. Just doesn't quite fit that history that we talked about, jumping for a ball and landing, yelping. It's still there, right? We could see dogs that have a developing neoplasia, bone neoplasia, and then they do some trauma that fractures it, and we've got kind of an acute onset of lameness. So still on the list, but it's also a young dog, not super likely. Septic arthritis, again, based on exam findings, would have to be on the list, but doesn't quite fit our history. So we started with some x-rays, of this dog's knee. And so I'll give you a little second to look at those and figure out in your mind what you think's going on here. But what this dog has done is fractured its medial femoral condyle. So if you look at this is the dog's medial femoral condyle, it should be sitting up here. This is basically the articular surface of the condyle that's kind of flipped out. So this is the fractured segment. So this part here should be flipped back up in here to the joint. So the whole medial condyle is kind of flipped caudally into the stifle joints. And then on the AP, here's our medial femoral condyle sitting out the back. So this is a pretty unusual injury. I've seen maybe 3 or 4 of these over the years. Usually some heavy jump coming down, twisting, and they manage to fracture this medial femoral condyle, and it always kind of goes out the back of the joint like this. And you'd think that maybe the medial collateral ligament would be involved, but these guys usually are still pretty stable with the medial collateral, and they just kind of pop that condyle out the back. Unfortunately, at this stage, we don't have a lot of great options, as far as what are our treatment options at 5 weeks post-injury. We certainly can explore the stifle and see if we can reduce this condyle, but I would tell you these are tricky to reduce even when they're fresh. So if we see them a couple days or a week after injury, it's still pretty tricky to get that condyle back into position without doing something more aggressive like cutting the collateral ligament to get into that joint and move that back. Plus then, I would have some concerns over, how good our fixation is going to be able to be in this bone fragment that's been sitting back there for 5 weeks. It's probably pretty soft. It's rounded off. It's not going to fit back perfectly. Is it going to hold pins and screws and things like that we need to hold it in there? One potential would be we just remove the fragment. Maybe over time that would help as far as taking the fragment out versus having it in there, and then just deal with kind of long-term stifle arthritis management. Amputation would be an option, although the dog's functioning with the legs. If you remember, we kind of called it a moderate weight-bearing lameness. At this point, we probably wouldn't go straight to an amputation unless it proved that the dog is not using the leg much down the road. So this is kind of what we talked about with the owner of this patient. Ultimately, I recommended, let's do a stifle explore and see what we can do. And at a minimum, we remove the fragment. They elected to just kind of watch it and see conservatively, what happens with it and decide if they needed to do something like an amputation down the road. But, continuing with pain management and non-steroidal anti-inflammatories and seeing how the dog does. And I don't know, I wish I had some better follow-up for you on how the dog's done, but I've not seen him back since that time. But, I think you guys, certainly the majority of you all answered that question I threw out there. I think how I would have answered it. But I guess any kind of take-home message here would be, if this is kind of an atypical case and it just doesn't quite fit the mold, I would lead on the side of taking radiographs. I mean, I hear from clients and in records every day about how the surgical clinic will always repeat x-rays. We don't want to waste your money or waste the client's money. Surgeons always want their own images. And I would say that's generally not true. I would say if we're doing pre-op planning and we're going to do a TPLO, yeah, we're going to take our own images for that. We need them to be calibrated and sized for planning. What size plate we're going to put on, what size saw blade we're going to use, those kind of things. So we are always going to repeat those stifle x-rays for pre-op planning purposes. We do that just at the time of surgery, so it's not like it's a separate event. But I would also say there's a difference between taking diagnostic x-rays and x-rays we need for pre-op planning. And so if it's an atypical case, so like this one, where certainly a partial cruciate tear, may have been a possibility, but the dog just seems more painful, more effusion, more dramatic than what you would expect. Certainly would be worth taking some x-rays on. Kind of similarly for a lot of forelimb lameness cases we see, sometimes we do need to take some additional x-rays or repeat some x-rays, but having those initial diagnostic x-rays to give us some pointers on, are we moving towards the elbow, are we moving towards the shoulder, can be quite helpful. And I think, helps your clients in the long run kind of get them going in the direction we need to. A lot of times if we have a couple elbow images and we can say, yeah, the elbows look abnormal, we don't really need to repeat those x-rays. We can go to a CT scan, at that point and not really have to repeat images. So I would say if it's atypical, if it's a typical 3-year-old Labrador, got stifle effusion and it's got instability and its symptoms are typical of a cruciate tear, you don't need to x-ray those guys, just send them to us. But if it's atypical in a way, I would encourage you to take some x-rays. I mean, the other thing we could have seen on this case, and we see relatively commonly, dogs that are suspected to have a partial cruciate tear, maybe you're managing them for a long time, they're just not improving. They're getting more thickening around the knee, more lameness than what you expect. It's worth an x-ray. This dog has a distal femoral osteosarcoma, but was kind of suspected to have a partial cruciate tear for a long time. So I'd say anything kind of unusual, making you throw up some red flags, pop an x-ray would certainly be worth it. All right, Izzy, how are we doing? What was the long-term pain management for this patient? So You know, when I saw her, I think we continued on the nonsteroidal anti-inflammatory, been tolerating. I think it was on carprofen, had been tolerating that well. We were continuing on that. I believe we probably added in some gabapentin at that stage for this dog. It wouldn't be wrong to do something like amantadine for long-term pain management and see. Always turns into a little bit of a trial and error, but you know, I think what we see the most efficacy from always are the non-steroidal anti-inflammatories. So if the dog can tolerate those okay and not having any side effects, that's the primary thing we would use to manage that inflammation in the joint. All right, very good. Well, let's change gears a little bit here. So case 3, 8-month-old golden retriever. So this is a little bit more of a gradual onset, right? Forelimb lameness over about 6 weeks. When you talk to the owner says, yeah, you know, back when the dog was about 3 months of age, it had some trauma where it had right forelimb lameness, last for a few days, didn't seem to resolve, and the dog's been totally normal up until the last 6 weeks, and we've had this gradual onset of right forelimb lameness. On exam, you find kind of a moderate right forelimb lameness, some muscle atrophy when you can compare the left to right forearm. The right elbow, you know, there's some effusion there. So it seems to be stemming from the elbow. You got effusion, reaction to range of motion, palpation over the medial aspect of the elbow. The dog responds. Not getting much else. Shoulder seems normal. Carpus seems normal. So really seems like the right elbow is the source of the issue. Here are the radiographs. So I believe these films are ones that we took, but you know, I believe this dog came with some X-rays to start with, some lateral views of the elbows, and came with the diagnosis of elbow dysplasia. Based on the level of incongruency in the elbow. So when we look at this right elbow, and this is just the elbow blown up, we certainly have pretty significant incongruency in this elbow. So radial head here, anchineal process, semi-lunar notch coming around here to a point, right? And then comes down. And so we've got this big gap here. The top of the radial head should really be congruent with this semi-lunar notch. And we've got this big gap here between the radial head and the humeral condyle. And then you look here in the semi-lunar notch, also we've got gapping here. So this humeral condyle is actually subluxating distally out of that semi-lunar notch. And so by definition, yeah, we can certainly call this elbow dysplasia, meaning, you know, abnormality in the elbow joint. But I would say this is a little different than our typical congenital elbow dysplasia. And so again, we're going to use our left side, our normal side, to kind of compare to and look in this dog. Well, this is a much more normal looking elbow here. So congruency looks good. No real abnormalities there. So very normal elbow there. You start also looking at growth plates. So again, it's an 8-month-old dog. Here's our distal radial growth plate, still looking pretty open on our normal side. Starting to look pretty closed up here proximally. But you compare it here, definitely closed proximally, closed distally. So this dog is actually a premature radial physeal closure. It's resulting in shortening of the radius. The ulna continues to grow. And then what results is you get this pretty significant incongruency in the elbow. And you also get some incongruency in the carpus, typically. The other thing we see of the elbow is all this sclerosis in through here. And so this is typical, you know, one of the first things we tend to see with fragmented medial coronoid processes and dogs with more typical elbow dysplasia. You know, and in that respect, this dog's kind of like that, basically walking on its coronoid process. So putting all this weight through the coronoid process would be pretty likely that it's got a fragmented medial coronoid process. as well. These are just the AT images when we're looking at this elbow. Again, on this right side, we've got this pretty big gap here between the top of the radial head and the humeral condyle. Looking at the left is our built-in normal. You can see kind of normal congruent joint space here, big gap over here on the right side. So this dog, like I said, is diagnosed with premature radial physeal closure. It's resulting in pretty significant elbow incongruency and a suspected fragmented medial coronoid process. So the question is here, what are our treatment options surgically? The primary abnormality in this dog is that short radius. So if we want to, quote unquote, try to fix that or improve on that, that means lengthening the radius back out to a more normal position and having it catch up with the ulna. The best way to do this, to lengthen a bone, is to do it gradually with something called distraction osteogenesis. So this is where we typically will use a circular external fixator, put on the radius in this case, or whatever bone we're dealing with, do the osteotomy, and then we gradually lengthen the bone at about, depending on the dog and the size and what's going on exactly, but usually about 1 millimeter a day, we will lengthen the bone. So you can't really acutely do this. So you can't go in, make a cut, and stretch out that radius a centimeter or more because of the soft tissue constraints there. Just will not allow you to distract that and say put a plate on it or something like that. So the only way to really get this kind of lengthening procedure is typically with distraction osteogenesis. The other potential surgical option would be an ulnar ostectomy. And so the idea here, just kind of going back to our image, is if you take some bone out, you take a good section of the ulna out, that perhaps it collapses down enough to help with some of this elbow incongruency. I would say we have less control over what's going to happen there. We can take a wedge of bone out and maybe we'll get some movement and some improvement in the congruency of the elbow. You also have the triceps pulling the ulna, the olecranon, in the opposite direction. So the triceps are pulling it this way. You're hoping weight bearing will push it this way. And I would just say you have less control over what's going to happen at that elbow level. And then because of the pretty high suspicion for fragmented medial coronoid process, the question would be, do we scope the elbow and take a look at that and deal with that at the same time? So this is what we decided to do in this dog. We're doing a radial lengthening procedure. We started with scoping the elbow and taking a look, and just to orient everybody here, kind of on the top left, we've got the scope in the medial aspect of the elbow joint. This is going to be the humeral condyle, the medial aspect of the humeral condyle here. The coronoid sits here, and this is actually a big fragment here. So a big fragment off the coronoid. Here's another little fragment off the coronoid. Typically, you'd see the radial head sitting here. So this is kind of where we expect to see the radial head, but this is actually a fragment. If we come in here with a little needle, if you can see that, and kind of push up that fragment, you can see a little bit of the bone surface. And so this is a fragment. If we kind of pan in the back of the elbow, so now we're going along the semilunar notch back to the anchineal process here, you can see we've lost cartilage in through here. We've got exposed subchondral bone, a little bit harder to see, but there's some cartilage loss here as well. And this is from not having normal contact, in that joint. We've got the humerus kind of subluxing out of here, and the cartilage starts to degenerate and such. And then this image is just after we've cleaned up. So we get little graspers in here, we grab these fragments, we get them out, we clean them up. Here's the edge of our coronoid process. This is where our radial head should be, but all we see there is joint capsule because that radial head is distally displaced and out of the joints because it's short. So here's post-op films after we put the circular frame on, and these cases are actually relatively straightforward. The benefit in this dog and many of these dogs with these short radial injuries or radial physeal injuries is a lot of them will stay pretty straight. You know, so if their alignment is good, we don't have to mess with the alignment. We don't have to do big corrections with alignment. We only have to cut the radius and lengthen the radius. We can keep the ulna intact. And so that makes the whole system stronger. We need less fixation for the radius. Now, some of the cases say if this is an ulnar physeal injury and we've got a really short leg and we've got a lot of valgus deformity, then we got to correct that as well, which means we're cutting the radius and the ulna. And then correcting for the deformity and then stretching them out from there. But this image, you know, it's kind of hard. There's a lot of metal on here, but maybe if we look at this image to kind of describe what's going on here, we've got just a couple little K-wires. So a little K-wire that comes across the radius here. There's two of them, so two divergent K-wires just getting into the radius only, so staying out of the ulna altogether. And again, up here, we've got two K-wires crossing the radius just to grab and fixate on the radius there. And then we've got these external rings that attach to those K-wires. And then in between the two rings, we got a ring here, we got a ring here. In between, we've got these bolts, and it's got a little threaded nut here on it. And so we've got three of those that are holding the ring stable. Then we go ahead and just a little mini approach, little centimeter approach, and we go in here and we cut our radius. So we do a little osteotomy on our radius, and then that's it to the surgery. This dog, you know, then goes home, and the owner actually distracts it daily. So again, we're typically moving these guys about 1 millimeter a day. And it's set up where this is a four-sided nut. And so as you turn it one entire turn around, it equates to 1 millimeter of distraction. So each quarter turn, you know, is a quarter millimeter. And so we do that about 4 times a day. So it's a very slow distraction. The dogs, you know, at that rate, don't even feel it. So they don't even react to a little quarter turn 4 times a day. If we tried to move it a couple millimeters, right, they would react to that. But if you're doing a quarter millimeter every 6 hours, they don't even, you know, seem to know that you're doing it. And so we have the owner distracted based on our calculations of how far we want to distract this radial head back into the elbow. I think on calculations, we had about a 6 or 7 millimeter gap here. But it is going to move both directions, right? So it's going to move towards the carpus as well as towards the elbow. So I think we started with about 10 days of distraction, and then I had to come back for a recheck. But this is the dog post-op, I think the day post-op, and you can kind of see the frame on it. We wrap it with a little bit of a soft padded bandage just because we got some wires and things sticking out there that they can catch on. I don't know if you can see it very well, but this little black nut is what they turn. They got little 1, 2, 3, 4 on the side, so it makes it pretty easy. You go from 1 to 2 to 2 to 3 to 3 to 4. It makes it pretty easy for the owner to distract. But this is the dog coming back in 10 days, so we've distracted it for 10 days, so what equates to about 1 centimeter. And probably easiest to see on this AP image, but we've got about 1 centimeter gap here now. So we're doing what we wanted to. The radius is, we're growing it. And you kind of look up in the elbow here, much more congruent. So we're pretty close to where we want to be there. And you look on our lateral image, you know, it's never going to be normal because this dog's kind of has growth and development happening in this abnormal elbow, but we're getting much more congruent. We don't have as much subluxation of the humeral head, and we're pushing that radius up where we want it. So everything is looking good at this stage. We decided let's just distract another couple days. We've got another couple millimeters, and then at that point the owner can stop distracting, and then we leave the frame on, and that works as our external fixator basically until we get that gap filled with bone, and then we can pop that fixator frame off. And This is just a little video. I believe this was the day she came in after 10 days of distraction. So you can see the dogs are relatively comfortable. I think she was still on the NSAIDs and probably gabapentin and I think some trazodone. She's a pretty high intense puppy who's bouncing off the walls most of the time, but she's a little sedate at this time. But you could tell, you know, she moves pretty well. She's weight bearing it nearly as well as she was pre-op. So they can be pretty comfortable with these frames on. We did have the patient in just, I think, about last week or so. And so this was 4 weeks after we stopped distraction. So basically, we're just waiting at this stage for that radial osteotomy and gap to fill in. And we're pretty close. At this point, if you look at the gap here, we've got a lot of callus forming. It's almost bridged. We took this one at a little bit of an oblique angle to see the osteotomy a little bit better, but we're almost bridged here, which is pretty amazing when you think about it. You know, we had what ended up being a 12 millimeter gap. And the other advantage of doing this slow distraction is these things really fill in quickly. So it actually stimulates bone healing and healing that gap. So we ended up leaving the frame on for another couple of weeks, and then she's due back for an x-ray, which I assume will show more complete bridging of that gap at that point, and then we'll take the frame off and then gradually get her back to more normal activity. So these are fun cases. Requires owners that you know feel comfortable with a wrench and can do a little distraction with the fixator, but certainly can be kind of pretty fun and interesting cases to work on. All right, how are we doing question-wise? We're good. Everybody's good. Everybody's like, oh yeah, interesting. Oh, we got one question. What's the most common cause of the initial pre-physeal closure and impact on leg? Question mark. Yeah, I would say. I mean, you know, it's kind of variable. I mean, often the story is, you know, kind of like I said with this dog. I want to say this dog, the owner felt like she got the leg caught in some sort of drain pipe or something like that. She was walking along and got it caught in some hole, and then became acutely lame afterwards. But yeah, some sort of jumping down off of things, landing on it, or, you know, torquing the growth plate. You know, this is probably one of those that, you know, if you x-rayed it at the time, probably wouldn't see much. Maybe you see some soft tissue swelling around that distal radius, but, you know, no displacement or anything. It would be more of a compression, probably injury or partial injury to the growth plate. All right. It looks like we only got a few more minutes. I don't want to keep you guys. If you guys have to go off to do something, feel free to jump off. I'll maybe try to breeze through one more case here and then be happy to take some more questions if you guys have it. But this is a 10-month-old mixed breed, kind of moderate sized dog. So about a 45-pounder, 21 kilos. Has a history of bilateral hind limb lameness, weakness lasting over the last 3 months or so. So maybe starting, you know, back when the dog was about 7 months of age, but really presents to you guys with an acute onset of left hind limb lameness, which started about 2 days ago. The dog was playing with some other dogs and became acutely lame on the left hind. On your exam, pretty severe, but weight-bearing left hind limb lameness. When you feel the left hip, dog seems to react to range of motion. The greater trochanter seems a little off. Maybe it's a little dorsally positioned compared to the right side. On the right side, you notice a positive Ortolani sign. Left side's pretty tricky. The dog's reactive enough. Kind of hard to tell if there's an Ortolani sign on the left side or not. Everything else orthopedically seems fine on your exam. Differentials, yeah, certainly a left hip luxation would be on the list, given the dorsal displacement that you felt on exam. Could that be a hip fracture? Yeah, certainly that could be a fracture. Maybe a growth plate, capital physeal fracture would be on the list. And certainly hip dysplasia with what amounts to more of a spontaneous left hip luxation. So here's our X-rays of this dog. This is what we found. And so you're looking at the left side here and saying, oh yeah, doesn't look like a normal hip. That could be a luxated hip. I'd say you can't tell for sure. Some of these could be just looking at the BD image, hard to say for sure. Is this a severe subluxation or is this completely luxated? And that's where your lateral image comes in. So if you take a lateral image with the pelvis pretty straight, overlapping, you can tell this head sitting up, dorsally out of place. So this is a complete luxation of the left hip. Obviously this right hip is dysplastic as well, pretty significant subluxation on the right side. A little bit of early osteophytosis, so a little osteophytosis around the femoral neck area. But this dog's now acutely luxated, almost a spontaneous luxation of the left hip. And the question I would throw out to the group here is, kind of what are our treatment options for this case? I mean, what's on the list of what we can do with this? So I'll throw it out for another quick poll and see what you guys think. Is closed reduction something we should be thinking about? Should we try to pop this left hip back into place? Or should we send it to a surgeon for open surgical reduction and then some sort of fixation, whether that's a toggle pin or that's an extracapsular stabilization? How about a triple pelvic osteotomy? Certainly a young dog, 10 months old, and is this a candidate for a triple pelvic osteotomy? FHO, is FHO kind of our only option for this case? 10-month-old dog, that might be the case. Or total hip replacement, is that an option for this dog? At 10 months of age, could we think about a total hip replacement, and what does the timing look like for that? So I'll give you a quick couple seconds to weigh in there. You want to post them? All right, so here's the results. They might still be in process a little bit, but you got your answers in. So, we kind of got it all across the board. As far as potential options for this case, with FHO kind of leading the way at 35%. So maybe I'll just kind of quickly go through here. I just need to get off. Okay. I'm not showing anything. Am I good? Hold on one second. I lost the screen. Yeah, I'm off to Zoom altogether. Am I back? Okay, I think I'm back. Sorry about that. I'm not sure what happened there, but just to go through some of these. So closed reduction of the left hip, not even worth really trying. I mean, this thing is so loose, this dog's so dysplastic. If you tried to reduce this, you'd probably get it back into place, but it would immediately pop back out. So no chance of success with trying to pop this hip back in closed and getting it to stay there. And I'd say the same thing with open surgical reduction. So This dog is so dysplastic when they have these spontaneous luxations with pretty minimal trauma. Our chances of being able to do an open surgical reduction and get that to stay without having normal bone anatomy there, to have a really open and dysplastic hip, getting that to stay even with toggle pins and these kind of things is pretty limited. I typically wouldn't even recommend trying that. Triple pelvic osteotomy. I mean, the dog is kind of an age that we think of for triple pelvic osteotomy, but without going into great detail, the dogs that do best with TPOs are dogs that have pretty mild subluxation. Once they get to even moderate or severe subluxation, we tend to not think of them as great candidates for triple pelvic osteotomy. You just can't rotate that acetabulum enough to capture that head. So certainly a dog with severe subluxation or a complete luxation of the hip is not going to be a candidate for a triple pelvic osteotomy. FHO obviously would be an option for a dog like this. Not a huge dog. I think what we said was 45 kilos or 45 pounds. It would be an option. Certainly the dog would have, comfortable life, with an FHO. Probably a little bit of stiffness, a little bit of weakness, compared to a normal hip. And total hip replacement is certainly an option, so even in our 10-month-old patients, it's certainly an option. Kind of the typical recommendation for hip replacement is let's wait till they're about a year of age if we can do that. But when they luxate like this, it kind of forces our hand a little bit, and we have to think about doing it earlier. So the risk is if we leave the dog in a luxated position like this, hard time advancing the slide. Here we go. Sorry about that. So if we leave them in a luxated position for a long period of time, then it's going to prevent us from being able to do a hip replacement. So we could go in, we could put the implants in, but we can't get them back into a normal position because of the tension with the soft tissue. So the muscles contract, fibrosis occurs, and we just can't get them back into a normal position. And if we do it, if we are able to accomplish that, they're at a much higher risk for reluxation after a hip replacement. So, young dog like this, hip replacement is a possibility. And if they're luxated, we got to move with it a little bit faster. So this is what we did with this dog. We did a hip replacement. It's not an emergency. I mean, after they luxate, ideally we probably get them in within 4 to 6 weeks or so, getting them into surgery and getting it back into a normal position and replacing that hip. And from a functional standpoint, if you can replace that normal mechanics to the hip and have the ball and socket joint, certainly the dog, will do a lot better. This is just another similar case, although even a little bit worse off, right? So this dog is bilaterally luxated at 8 months of age. So we tried to wait a little bit. I actually first saw this dog at 6 months, and we tried to wait a little bit, but then she became bilaterally luxated, and we decided if we're going to do a hip replacement, we need to do it pretty soon. So in this dog, we actually did staged bilateral hip replacement. So we did the right side and waited about 2 months and did the left side. So at 8 months, we did the right. At 10 months, we did the left. And even with that left side was a little tricky to get that back and reduced. We certainly couldn't wait too much longer. This is that particular patient. She's at about 3 months post the second hip right now. So just starting with some off-leash activities and starting to get back to some normal activities. You can see she's moving pretty well. She's building muscle on the back legs, and she's certainly a pretty happy dog. So just threw that one in at the end. I don't know if we've got many people still here, but what questions do we have, Izzy? Is there an expectation of failure for a dog this age with the THR? No, I mean, we don't expect it to fail. I assume you're talking maybe more long term. I mean, short term, risks and complications would be the same with any hip replacement. We've got to give it time for the bone to adapt to the implants. Slips and falls or torques or things like that could luxate the hip. We worry about implant loosening early on. Almost always now, especially in our younger dogs, we're using cementless implants. So those are implants that are kind of more texturized to kind of mimic the bone. Bone will actually grow into the implant, and that gives us really good long-term stability of those implants down the road. So we don't worry really too much about those implants loosening on us down the road. Now, and certainly in a person, you kind of hear about, well, implants kind of wearing out, or they wearing out that polyethylene liner over time. People are certainly, if you're a younger person and get a joint replacement, maybe that's a bit of a concern, or if you're a big time athlete, so if these dogs, I really wouldn't worry in a dog's lifespan if they're pretty normal pet quality, kind of activities and expectations. I really think pretty low risk they're going to wear out, so to speak, their implant. If this was a dog that's going to go, jogging with the owner 10 miles a day and that kind of thing, yeah, over 10 years, you might think we might have some issues with that implant. But I think normal pet kind of quality activities, I really wouldn't be worried about the long-term aspects of those implants. Once we get them healed and we get them to that 3-month mark and that the implants are stable in the bone and we've got bony ingrowth into the implant, and we're feeling pretty comfortable with those. It's like we got another one. It seems like the trend is away from TPO in younger dogs with mild to moderate dysplasia and weight for THR when older. I mean, I think that is accurate, statement. And I think that kind of developed for a few reasons. Over the last 10 years, we have changes in implants, like cementless implants, that are more and more successful. So we have younger and younger dogs that we can do hip replacements in and expect good results and good long-term stability of those implants and long-term success. Where when we started off, I mean, kind of just like on the human side, you'd wait as long as possible before you do a cemented hip replacement to get those dogs a little bit later, because we're worried about the long-term success. So I think on one side of things, we're getting more and more comfortable with doing hip replacements in younger and younger dogs, younger in patients, and having good success with that. And then I think it, and critically looking at our dogs with TPOs and trying to determine how successful is that. And I think it could be pretty successful in the right patient, but that right patient tends to be dogs that have very minimal symptoms and mild subluxation. And often those are the cases that aren't coming into our office with significant symptoms. And so they kind of get missed, those kind of ideal patients for TPO. And the patients we tend to see, if they're of the kind of right age, tend to be dogs that are more significantly affected because they're having symptoms and owners are bringing them in and for evaluation. And then, we can do a TPO on some of those dogs that are maybe moderately subluxated, but then, it always comes with the kind of caveat that we might have to do something else down the road. Do we need to do a hip replacement down the road if we can't control their symptoms, adequately with medications or conservatively down the road? So, I think, having that discussion with owners, a lot of them are opting, if we're not an ideal candidate for a TPO, let's wait. Those are usually dogs that maybe we can manage their symptoms for a number of years. And then we think about a hip replacement when their symptoms become, more significant and consistent. All right. Anything else? Cost of a hip replacement. I'd say generally, right now, I mean, if you kind of go through what we need for kind of workup and evaluation, we usually It's a couple of visits, one visit to get in and get some x-rays that we can template and plan for surgery and such, and then coming back for surgery, and they're usually in a hospital for 1 to 2 nights, and then you got some, recheck x-rays down the road. I mean, probably all told, I would tell your clients that they're probably looking around the $10,000 range by the time we're done with everything. A lot of that, the big chunk of that is the implants. The implants are not cheap. All right. Well, thank you all again for spending your lunch hour with us. I hope you guys were able to gain a little something or a little few nuggets from this that you can take with you in your daily practice. But definitely, again, I extend to all of you guys, if you have questions about cases, is it surgical, is it not surgical, where do we triage it, can we get it in sooner, does it need to wait, with everybody else with chronic injuries, send us your cases or call us on the phone. We're happy to talk to you, at any point. And then just one more time, I want to thank Hills and Elanco for their support and helping us put on these CE events. So hope you guys enjoyed it. Let us know if you have, any kind of recommendation for future events like this. For the few of you that are still on, we're happy to also take your cases. I think on the invite, we said if you had some unusual cases or something you wanted to talk about, we'd be happy to put them on if you send them to us ahead of time. And that we're still totally open to that. I think we'll do a few more of these in the future. And, if you're brave enough to put out a case, we're happy to talk about it and talk through it with the group. So thank you again. Thanks for spending your lunch hour with us, and take care. Enjoy the sunny weather today.